The ACCC Annual Achievement Award was established in 1980 to recognize distinguished individuals or organizations that have reflected the values of community cancer care through their outstanding contributions to the field. I am delighted to present this year's award to Dr. Lori Pierce. Dr. Pierce is a radiation oncologist, professor, and vice provost for academic and faculty affairs at the University of Michigan. She is also the director of the Michigan Radiation Oncology Quality Consortium. A national leader in breast cancer research, Dr. Pierce was previously a senior investigator at the National Cancer Institute, National Institutes of Health, and in 1992, joined the faculty at the University of Michigan, where she has focused her career primarily on the treatment of breast cancer. Dr. Pierce is the immediate past president of FASCO, the American Society of Clinical Oncology. She made equity the theme of her 2020-2021 presidency, and we had the distinct honor to work with her as we launched the ACCC Community Oncology Research Institute, featuring a joint initiative to increase racial and ethnic diversity in clinical trials. There's been a perfect match between her, ASCO, and world events, says Dr. Theodore Lawrence, professor and chair of the Department of Radiation Oncology, who's worked side by side with Dr. Pierce for many years. Racial and gender equity have been one of her biggest issues. With over 180 manuscripts and book chapters published, Dr. Pierce has received numerous teaching and leadership awards, including the American Association of Women Radiologists Marie Curie Award. She is known as a role model, a mentor, and a leading advocate for addressing equity issues in healthcare in general, and specifically in cancer care. Welcome, Dr. Pierce.
I am so appreciative to Ms. Nelson and to ACCC for this gorgeous award. I was so surprised and happy when I heard I'd been chosen to receive it, and it is so special to think that others feel that my work in cancer has made a difference to patients. And so I thank the leadership and the members of ACCC so very much for this honor. As I think you know, I'm a radiation oncologist and I'm at the University of Michigan, where I've had the privilege to care for breast cancer patients since I finished my residency in 1989. And I also serve as vice provost for academic and faculty affairs at the university. And in that role, I oversee all matters faculty, all matters concerning faculty in our health science schools. And I've had the opportunity to work and support faculty across campus in many aspects of faculty life. But today, of course, I want to focus on work that I was able to do while I was president of ASCO and work that I continue to do as part of the ASCO leadership. And it's work that is fundamental to ASCO. ASCO has been involved in equity work since day one. And my theme, equity every patient, every day, everywhere, really underscores the importance of equity of care for patients with cancer. And this slide, I put this slide in here just as a reminder for me to comment that equity in cancer care has to be considered along the full continuum, from prevention, screening, diagnosis, treatment, and recovery and survivorship and end-of-life care. It's so important to consider health equity along the full continuum of patient care. And this is a slide that I created a few months ago that's really focuses on all of the factors that are involved in equity. I always say that equity is such a simple word, but it seems to be so difficult to achieve. And I think it's that way because there are so many factors that enter into equity of care. And I put just a few of those factors on this word cloud. It's such a simple idea. And certainly for this group, everyone is well aware that there are differences in incidence and outcome rates for cancer by race in this country. And this is data from the NCI Cancer Stat, Facts, and SEER that just looks at the variability in incidence and survival rates for people in this country with cancer. And we know that Black men, for instance, have the highest incidence of cancer and the highest death rate of cancer for any of the major ethnic and racial groups in this country. And so it's very important for us to be aware of the unevenness, if you will, in cancer outcomes by race. And, we know that some of this is due to biology, but there's a lot more than biology. And certainly the social determinants of health are very important factors in dictating outcomes. And I always call these the invisible factors. And these factors undeniably affect the outcome of people with cancer. Economic stability, neighborhood and physical environment. People live in safe neighborhoods. Can they go out and exercise without worrying about crime? Education. It's so important for people to be educated, to know how factors affect health outcome and what they can do to minimize those factors and improve their outcomes. Food, access to healthy options. That's not something that everyone can access. Community and social context. We know discrimination is bad, stress is bad for outcomes. We know support systems are so critical. And then obviously healthcare systems, healthcare coverage, having providers that are culturally competent and having quality of care. So many factors that are involved in outcomes. And so with that, one of the initiatives that I was able to move forward in ASCO was the Social Determinants of Health series. And it's a new initiative that really focused on providers really understanding the social determinants of health and their impact on patients and outcomes and modifiable risk factors for cancer. And so we launched an initiative where we had a series of videos and podcasts on various aspects of social determinants of health. And I'm happy to say that this effort is going to be expanded within ASCO. We know that one of the barriers to equitable care is underrepresentation of minority cancer providers. And there was a recent paper here that just showed that if you look at subspecialties following internal medicine residencies and what people chose who were minority candidates, the lowest was oncology. So we were the lowest. And it shows that there's a lot more we need to do to increase the diversity of providers. And to that point, this past year, we had the first year of an oncology summer internship, which briefly is a 4-week immersive experience for students who are underrepresented in medicine between year 1 and year 2 of medical school. And it gives them a chance to really understand the wealth of programs that are available and careers in oncology. And we just had the first year. It was very, very well received. And we are now taking applications from medical schools for the second year, because for those medical schools that are accepted, their students can then participate in this program. So I would encourage you out there, if you're affiliated with any of the major medical schools, to please apply because it was an amazing experience. And then this year, as many of you probably know, ASCO and ACCC have formed an ongoing collaboration to increase diversity in our clinical trial populations. We've worked together with advisory groups, both physician and care providers and patient advisory groups, and we've gotten extremely valuable feedback from members of both ACCC and ASCO to really understand what it's going to take to help institutions to improve enrollment of minority patients. And so we actually have created a site self-assessment tool so sites can decide and understand if there are barriers within their system that are minimizing minorities from entering into clinical trials, and also to educate care providers to mitigate biases. And we have a pilot. We thought we would have about 40 institutions, and we had 75 institutions from across the country, all different types of sites and different geographic locations that are piloting this tool. And once they give us their feedback, we eventually will publish the results of the study, which hopefully can be widely disseminated for those who put patients on clinical trials. So extremely important initiative, and so wonderful to have a collaboration between ASCO and ACCC. A little bit about my work, my clinical work and research. My focus is on caring for women with breast cancer, and something that I've been working this in 1989. We know that the incidence rates between whites and blacks for breast cancer is now about the same. It used to be a lower incidence for black women with breast cancer, and now the incidence is about the same, but there's a 40% higher death rate for black women with breast cancer. And we know that African-American women of West African descent and Latinas are more likely to be diagnosed with estrogen receptor negative disease, and African-American women are twice as likely as white women to have triple negative breast cancer. We're not sure exactly why that is. There are possible etiologies, but we know that there is a more aggressive phenotype in African-American women overall than white women. And so we know that it's more aggressive because it's more difficult to limit systemic recurrence, and it's also more difficult to limit recurrence in treatment of the breast. And that a lot of that's due to radiation resistance. And for that reason, some of my research is really focused on trying to find ways to increase radiation sensitivity for triple negative breast cancer and for other resistant breast cancer phenotypes in all women with breast cancer. And just very, very briefly, this is some unpublished data from a few years ago with colleagues, Dr. Fang and Dr. Spears. We worked together in terms of combining various systemic therapies with radiation to increase radiation sensitivity. And this is an example where we combined PARP inhibitors with radiation. And we found that by doing that in many of these cell lines, we did in fact see a much greater radiation sensitivity, including basal subtypes. And this work led to a phase 1 trial where we combined PARP inhibitors with radiation in cancers that were recurrent, as well as those with inflammatory breast cancer, which is very, very hard to treat. And the data from that trial then has led to a current national randomized trial with PARP inhibitors and radiation for patients with aggressive inflammatory breast cancer. And I'm happy to say that I'm the director of a statewide radiation collaborative quality initiative, and this is in the state of Michigan. And these initiatives, there are multiple quality initiatives for various clinical goals. And these are partnerships of physician practices across the state which focus on improving patient care. And these are all funded by Blue Cross Blue Shield of Michigan. And again, these are physician-led collaboratives composed of physicians at hospitals throughout the state. And they come up with goals. We come up with goals that we collectively agree upon, and then best practices are rewarded by Blue Cross and Blue Shield. And I'm the director of MROC, the Michigan Radiation Oncology Quality Consortium, and that seeks to improve the quality of radiation delivery across the state and to guide the appropriate use of high-cost technology in radiation treatment. We want to be judicious in how we spend, how we use the precious resources in healthcare. We want to make sure that we improve outcome for patients with cancer. And so our mission is to improve the quality of radiation therapy throughout patient-centered care. Our vision is to expand access to high quality care. And our values are based upon patient-centered care, evidence-based care, collaboration, and respect. And our goals are, as you see listed here, and certainly include delivering equitable care. So I come back to the theme that I had at ASCO, equity, every patient, every day, everywhere. And I thank you all in ACCC for all you do to deliver high quality, equitable care to your patients. And I thank you so very much for this incredible honor. It is just amazing. Thank